Sure. So, of course, we want to start with a land acknowledgement, and just want to say that the Center of Excellence for Women's Health, where we work, respectfully acknowledges the First Nations, Inuit, and Métis peoples as the original inhabitants and traditional custodians of the lands where we live and learn and work. And we honor Indigenous knowledges, histories, traditions, and rights, and remain committed to fostering meaningful partnerships, both in general and in the context of the project that we're speaking about. To challenge systemic inequities and support the health and well-being of Indigenous women and girls and all peoples. Thank you. So as objectives today, you can see here, we want to reflect on the common elements of evidence-based interventions that address both IPV and substance use amongst women, to expand our understanding of how the substance use field has evolved over the past decade or so, particularly regarding the expanded concept of recovery. And we want to discuss, as feminist scientists and advocates, our role and encouraging and providing dual-focused support. So thank you for coming to hear about this. You can skip that. You've already heard who we are.
Okay, so the way we organize this, we have a few questions. And the first one is, what is the relationship between substance use and intimate partner violence, gender-based violence?
Yeah, so the relationship is complicated, but strong. In other words, as I think I mentioned yesterday in the TVIR panel, when we were talking about our specific project, Strong Women, the majority of women who have experienced IPV or GBV have used substances or are, and vice versa. The majority of women who are using substances have experienced IPV. And this is not a new development. This has been well established for decades. And it is one of the reasons why we do the work we do in the way we do it, constantly trying to integrate these two issues. They obviously also hook into other issues that are structural and social determinants of health. And that is a big part of the story, always. But what we're going to try to do today is converse about some of our thinking after recognizing the overlap here. So one question that often comes up is, just what is substance use? And one of the things that we like to talk about a lot, because it helps in understanding the vast array of substances, is that there are different kinds of substances. It's not just one thing. And those different kinds of substances have different impacts on people, bodies, and groups of people. And that's worth learning about. Just to be very broad in our categories, for example, we have legal drugs in Canada, we have illegal drugs in Canada. It doesn't take too much to imagine how even those two categories mean some very different outcomes for women or men, in fact. So the legal ones are of the most concern when we look at issues of health, issues of recovery, issues of prevalence. The ones that matter the most in terms of really needing a lot of our attention in the GBV sector are alcohol, tobacco, and cannabis. Cannabis, a bit newer on the scene in our country, but nevertheless already a big player. And that's different sometimes from what we think about when people say substance use. We think about injection drug use or cocaine or meth or heroin or fentanyl or street life or very difficult interactions with the criminal justice system, or irrational behavior, or intoxication, or unpredictability, or death from overdose. So right away, there's some really different things that are in that category, substance use. And, we've got a lot of different dynamics that play in. Some of those things involve, I'll just touch on some, coercion, substance use coercion, which is a thing, and it's been well documented. Sometimes it plays into perpetrators influencing women to get involved, even for the first time, in substance use. Any of the things I've mentioned, legal or illegal. Sometimes it means getting women to do certain things in order to make money to buy some of those things I've just mentioned. Sometimes it's way more subtle. It's things like sabotaging women's attempts to recover. And, that should concern us all in the GBV sector, because when you're encountering a woman who might come to your services, you're actually dealing with somebody who wants recovery writ large, and progress and hope. And a big part of that journey often is for her to address some of her legal and her illegal substance use, and to look at the roots of it, the meanings of it, and how she might, in fact, feel more liberated if she were out of it. And, that is really crucial, because these issues overlap so obviously then when you think about the dynamics. So that kind of coercion about substance use can work both ways, many ways. It can get women started. It can prevent women from quitting. It can force women to quit. Sometimes we see that dynamic during pregnancy, where partners who are abusive all of a sudden feel like they're in charge as a whole unit and want to make comments about forcing quitting, all of which are coercion. So there's a lot of dynamics to think about here, and a lot of different drugs. I hand it over, Nancy, if you want to talk.
Well, maybe you want to,
Yes.
Andrea.
So, as Lorraine touch upon this, the relationship between substance use and IPV is multifaceted and bidirectional. Perpetrators use it as a disinhibition. Alcohol facilitates violence, but doesn't cause it. Sometimes alcohol is used as a justification for violence. And alcohol impairs cognitive processes, making it harder to process the emotional or physical harm being caused. We also know that perpetrators experience intergenerational adverse childhood experiences, and evidence shows us that men who witness or experience IPV or violence are more likely to use alcohol as a coping mechanism. And we know from the literature that women with histories of childhood trauma are more likely to experience intimate partner violence later in life, and also use alcohol as a coping mechanism. And some women may turn to illicit drugs as a way to numb emotional or physical pain. And alcohol or substance use may emerge as a survival strategy for women's responses to violence, such as shame, fear, isolation, mental health, systemic barriers. In some cases, women also turn to alcohol as self-medication to relieve symptoms to trauma, such as insomnia, PTSD, panic attacks. Survivors also use alcohol for navigating relationships, in some cases stigma, or fitting into the society.
So it has been so interesting, that we have gotten to this place in our development over the past 30 years in both the anti-violence field and the substance use field, that there is very little interventions that talk about these interconnections. And one of the things we've been working on in the last few years has been developing an intervention that Andrea will talk a bit more about this afternoon, but we've got some more information on here. But just really opening, as we hope to do today, the discussion about how can we not be siloed in these interventions and really increase our understanding of what works with whom in what context as we go along today. So we wanted to start with this idea of recovery that has really evolved over the last few years in the substance use field as a term that more adequately describes a journey, not a destination, but a journey to better health in the substance use field that has real parallels with the journey in the violence recovery path as well. And we've been really stuck in the substance use field where I've worked for more than 30 years with a lot of misunderstandings of what recovery looks like. And people often feel like, well, it just means you go to a treatment center or you go to AA and that's recovery. And we're here today to talk to you a lot more about what recovery actually is and how we might all engage in supporting it. Now, Lorraine's already talked a bit about these different substances, and I really encourage you to go online to the Center of Excellence site if you're interested to learn more about the gender and sex specific impacts of each of these substances, because we often don't talk about that. And these particular sheets on alcohol, cannabis, nicotine and tobacco, and prescription opioids and chronic pain are really helpful, I think, for your understanding, as well as in some cases for discussing with women themselves. We brought together women from all the treatment centers across Canada that provide gender-specific treatment for women and talked about what are the elements of recovery that we need to be researching and expanding and building on. And you can well imagine that trauma and violence-informed care was definitely one of the many ones that we talked about in that evolution of where we are in terms of really understanding recovery for women and moving forth from here. And just wanted to mention that the Substance Use and Mental Health Services Administration in the U.S. has done some great work of late on writing up this expanded concept of recovery, which you probably can't read it's so small here, but it does include health recovery, which substance use field has always been concerned with, but a lot more about having a safe and stable place to live, having purpose in terms of vocational things, daily activities, capacity to move forth in how we are living. And then the community piece about having relationships and social networks that provide support. And in the case of women who've experienced violence, really moving from that place of being alone to being in community with other women who've walked that path and taking strength from each other. And in this piece that we did on women's substance use treatment and recovery, the women's treatment centers across Canada really emphasized the women together as a critical piece of recovery. of understanding our experience in a patriarchal society and really being able to think through together how we can walk forward, not only for ourselves, but for all women who have been through these experiences. And I think that is one of the biggest commonalities the substance use field has had with the violence field. Now I'll turn it over to you, Lorraine, to talk a little bit more about dual-focused interventions.
Well, I think there's so many angles to this. I think, we have had a history in Canada of noting this overlap and making a few attempts to deal with it over the years, but never really getting to the point of integrating a dual focus in both of our sectors or silos, whatever you want to call them. So it really speaks to the issue of why that's happened. Partly it's funding structures and hierarchies, but also changing attitudes and values as we go along about just what the goals are. And I'm just going to digress for a minute. I think in the substance use and recovery area, you've heard Nancy talk about recovery. Recovery is the goal now in substance use. Harm reduction is a safety measure, but it is not a goal. And I really want you to think about that in the work you do. So you can provide increased safety among a variety of areas of substance use. That might be as simple as making your facilities, as happened some years ago, smoke-free. It might be about, providing other forms of harm reduction for illegal drug use. But that is not a goal of recovery. That's a measure. And so I really want to plant that idea that in our work on a variety of substances, and we can talk at length about alcohol, tobacco, cocaine, meth, prescribed opioids, cannabis, and we can tell you all the differential impacts that they have. But in many cases, they do lead to dependence and addiction. With respect to tobacco, for example, something that most people in our country think is the most benign of the lists that I've mentioned, is responsible for the most deaths and the most illness, and is 95% addiction. In other words, 95% of people who might start to smoke will get addicted to it. That is not true for the other drugs. We have other issues with the other drugs. With other drugs like alcohol, it can lead to, cognition impairment, intoxication, behavioral issues. It too can lead to disorder. Same with cannabis. What we don't know about cannabis is more than what we do know. So we're struggling in this country to try and figure out what the future brings in that regard. A lot of people think because it's legal, it's safe. That's not equal. And, with prescribed opioids and opioid use in general, that's often a track that women end up on simply because of gender issues and stereotypes, that they're prescribed more opioids, more chronic pain. So you end up with these different drugs with different risks. But the bottom line is none of this is liberating. And none of it is really going to assist in a recovery from both issues or either issue. So, that's one of the things I think I'm saying is that going forward and thinking critically, we actually have to think about what did these things do to us and start there. And people are often surprised, for example, when we talk about our research on tobacco and IPV. Basically, the use of cigarettes by women facilitates the perpetuation. Why? Because it actually suppresses emotion and anger, especially negative emotion. And women have said to us, we can suck back our anger. Therefore, we don't say anything. We don't cause trouble as long as we can smoke. Cannabis, we think, may have some of those impacts as well. It certainly is relaxing, and certainly women self-medicate, apparently, is what they tell us. But, you can begin to think, if you know more about each of the drugs that were mentioned earlier, you can begin to see how some drugs might actually facilitate women coping, but in ways that are self-harming as well. So, that kind of critical analysis is really super important. I think, as Nancy alluded to a minute ago, we do a lot of work on both sex and gender-related factors. I implore you, if you're going to work with substance use issues, you have to talk about sex-related factors as well as gender-related factors. It takes far less alcohol to do far more damage on a female body than on a male body. And if we don't think about that, then even simple things like drinking, low-risk drinking guidelines are not being publicized accurately, etc. So that's one of the critical aspects. The other critical aspect is, as I said a minute ago, not just settling for harm reduction, but actually thinking about recovery. And that really will require a shift, because we have had a long period in Canada where we have focused on harm reduction, which is not wrong, but it's not necessarily enough.
So I've been working over the past decade with a group of women across Canada who are involved as researchers, service providers, mothers with lived experience, and policy experts, and thinking through how could we prevent health in pregnancy and the risk for fetal alcohol spectrum disorder. And as we've been doing that work together, we have thought through this expanded concept of recovery in community-based pregnancy outreach programs, etc. That these fundamental components of prevention of alcohol use in pregnancy are important: respectful, relational, self-determining, women-centered, harm reduction-oriented, trauma and violence-informed, health-promoting, culturally safe, supportive of mothering, and using an FASD and disability-informed lens as we do the work. So I think it's just a real testament to how the GBV and the substance use field and those interested in health promotion and determinants of health have been able to see the way forward by working in a much more thoughtful, recovery-oriented way than just don't drink alcohol in pregnancy-oriented way, which you can imagine does not go well when you focus on the alcohol alone instead of thinking about, as Nadine mentioned, what has happened and what is happening currently in women's lives as they're making decisions about their alcohol use in pregnancy. So I do think we can bring this kind of critical analysis to our work that is complex and not overwhelming, but actually empowering for us, because we are actually working in a recovery-oriented model.
Stigma is a big part of the critique, and I think we can all speak to it in different ways. There's a lot of stigma attached to both issues. But I think we're going to go back and tell you about a historical project we did called Mothering Under Duress, which we did maybe 25 years ago, where we actually did a
Content analysis on how the media in Canada regarded women who had experienced IPV, women who were using substances, all mothers, and women who had mental health issues, all mothers. And I think you can easily guess who came out with the most stigma. And it was those women with substance use. And so, there is a bit of a long-standing problem there that, especially for mothers or for pregnant and parenting women, there has been huge stigma and huge gendered stereotypes about the use of substances. a lot of negativity that has seeped into the justice system, the healthcare system, but even the treatment and recovery system. And it hasn't helped. So, stigma is a real thing and it's a big thing. And I think, fast forward to 2025, where now the average citizen in Canada is face to face in most cities and towns with the impact of especially illegal drug use, but not only, and the repercussions with respect to homelessness and violence and mental health. And I think the stigma issue is really front and center again. So one of the questions we have to ask ourselves is, how can we destigmatize? And one of the critical things that we entered into in a project we did some years ago called Mothering and Opioids was to actually address that piece with healthcare providers. And we've published some work on this that you can access on our website that actually encourages providers in any setting, and this could be you, to examine your own stigma, your own attitudes, your own thoughts about substance use before you proceed, particularly when it's mixed with roles like mothering or pregnancy. And, this has a long history, part of the critical approach. Women have long been prescribed drugs, legal drugs, for decades and decades to pacify women, shut them up, keep their anger suppressed, keep them happy at home. We can go back a long way to the days of Valium and barbiturates and see those patterns. We've moved on a little bit so that now companies like tobacco and alcohol companies exploit women's aspirations for the same reasons, to sell things or keep women happy where they are. So it's pacifying. So these are some of the complicated feelings and attitudes that our societies and all of us have about the use of substances among women in particular, that we need to unravel in ourselves first and in our peers. So one of our resources actually gives you some ideas about how you can address comments in your peers, your co-workers. And certainly that was very informed by women who were mothers using opioids and what they said to us about what they wanted or needed to see changed. So stigma is no minor thing in this area. And it is a barrier. It's a barrier to not just the obvious of women getting treatment or recovery or a good reception, but it's a barrier amongst our own services too, about how we actually feel about some of these drugs and some of the people who take them.
Some of the pushback around the stigma has been in these moms' social media groups that really talk about mothers' rights to use alcohol to ease the process of caregiving. And there's one of the most recent ones. We've been trying to interrupt some of those conversations by joining groups and helping think it through. But one of the most recent ones had the opening picture of on Instagram was the mom doing a yoga pose with a glass of wine in her hand, right? And really advocating the importance of honoring the trials of motherhood by using substances. So I feel like we're way past the days where we said you can't come to a transition house if you have a substance use problem, or we're not going to talk about violence in alcohol treatment. We're way past those old silos, and now we're into new challenges around stigmatization and the pushback against critical thinking about how we use substances and see recovery.
Yes, a few years ago during the pandemic, we worked on a project, vaping in pregnancy, vaping nicotine and cannabis during pregnancy and or postpartum. and we asked women about their use. They told us a lot of things about stigma. We created 2 resources. We don't have the picture here, but we have the information on our website. And one of them was for women. We were answering questions that they addressed us because sometimes there is not a lot of evidence on vaping, especially vaping cannabis and also nicotine. And because sometimes women prefer to go to other resources and they prefer to ask their friends, they prefer to ask their family, they want to go to social media and ask questions there. We also worked on a conversational starter with the healthcare providers. As I said, this resource is on our website. You can see it there.
So let's talk about the programming and the response and some of the things we've seen that are the parallels between the substance use and the anti-violence movement. And do you want to start by talking about that rapid review that we did?
So also during the COVID pandemic, we work on a
lot of work happened.
Yes, we were busy. We started working on a project and we linked 2 different bodies of literature, one on natural disasters, pandemics and intimate partner violence, and the other one on intimate partner violence and substance use. And we conducted a rapid review. We work with our partners, CCSA, Women's Shelter, and Justice BC. We created different resources. One of them was an infographic, and we found that both fields work on these common principles. And that's how, later today, we're going to tell you more about strong women.
Do you want to talk a bit more about?
Yes. So in our scoping review, we found more than 4,000 articles, and we screened them. And 13 articles were included that had worked with both intimate partner violence and substance use. You can see this on our website. And I don't know if you want, I can share more details about this.
I think what we really found was there is very little that has really gone in depth looking at integrated approaches. There are common approaches used in both fields, but the actual offering of support on both issues together and helping women make the connections between their substance use and their experience of violence it's pretty slim. And one of the most common ones has been the use of the work in motivational interviewing that is about guiding and is about not directive approaches, but eliciting from women their understandings of what's important for them and guiding a process of understanding those connections and really using that idea of relationship, sharing of wisdom, building strengths and empowerment models that both fields have as foundations, and just thinking about how we can weave together those responses.
Yeah, I think at many levels you can do formal or informal actions within GBV services or advocacy groups or primary prevention even, if you start by just opening the conversation and acknowledging the obvious, whether it's a woman who talks about alcohol use or tobacco use or cannabis, or whether you observe it, or whether you just ask about it. Or sometimes it's simple things like having information available or a poster on the wall or something that opens up that conversation so that you can begin to make those links yourself between substance use of various kinds and GBV dynamics and recovery options that include those principles that we've just shown you. So it's really about how you can begin to very informally weave in some of this knowledge in yourself with the women who come forward and begin to plant some seeds, because this is a process, obviously, as you will know from the GBV sector. It's also a very long process with lots of ups and downs, the recovery process in substance use, and lots of relapse. I think we've mentioned at the program level issues around stigma reduction and training yourselves in that way, and even launching specific programs like the ones that actually do address dual issues. And there are some resources and programs, including the one that we were funded to do under the PHAC investment. And then Nancy's already mentioned the service linkage at the community level, and certainly the systems advocacy that's required.
Yeah, lots to think about. I think as we went along, we were thinking lots about how to start that process after women have accessed either substance use treatment or violence service. And we thought about the building of this Strong Women program that we've evidenced over the last 4 years in terms of kind of like being an aftercare process, because oftentimes in the anti-violence service, you're in the moment of having to deal with a crisis of violence and don't have the opportunity to talk as much about substance use as might be helpful. And the same on the other side about in the substance use field, not being able to adequately talk to women about the connections with their experience of violence. So this Strong Women intervention we've been working on is actually one that we've created for both substance use services and anti-violence services to offer as kind of a virtual aftercare support. So not necessarily, the woman isn't necessarily in your daily service, but one of your counselors offers the longer term group as an option that does allow women to take more time and to be able to do it in a way that they may no longer be in the same city as your service. They may have moved on. They may have, had all different kinds of changes in their lives, but can come back and access support from you as a service about the two issues. And we saw this as an imperfect, because virtual is always imperfect, but an important addition to our response on both issues that gave opportunity for you to be able to say in the context of your work, down the road, you may want to come back and connect to this virtual group that explores some of these issues together. and just planting the seed for women in the context of the first response to them, that this is an option that your organization has to begin that process of us actually having interventions that are focused on both issues together, rather than only, walking the path one way or the other. And it's really interesting, I think, how many women come in a door that isn't necessarily the one that's most difficult for them, because that they actually, given they have a number of issues, they're going to go in a safer door than the one that's most challenging for them. And I think by planting that seed in the context of your work, that we do have more support virtually in an ongoing way, can really be a super addition to your work in a way that is completely doable, even though there's lots of challenges with the virtual support context. But we see lots of opportunity. We've got about 5 more minutes before we open it up for discussion. We just wanted to kind of leave with this kind of empowering message, I guess, that this is doable. That even as we're supporting individual empowerment with women in our services, that this idea of virtual social support for women really taps into one of the key determinants of health, that of having networks and social support. And we see these issues as a way of encouraging women in that ongoing way to take strength from other women and to collectively think about where they can go in terms of changing their world. Because there's lots in this intervention that goes way beyond the individual recovery, but lots more about finding ways to give back, as is so commonly wanted by many women who've done these recovery journeys, is to have a way to give a hand to women coming behind. And also, as I've recently found in my own town in Victoria, women who've experienced violence really wanting to take on how their treatment in the justice system was not violence and trauma-informed, and really wanting to make the path better for women beyond their own situation. And this kind of work around that we've done in the Strong Women intervention really does create opportunities for women to discuss that together, about their interest in changing the world as well as themselves, and not seeing that as something you can only do after you're somehow totally recovered, but seeing it as part of recovery and building that sense of empowerment.
So it's no surprise that this is called Strong Women, that kind of positive recovery-oriented outcome and that empowering notion. And this particular PHAC-supported intervention that we're discussing a lot this week is, of course, about the blend of IPV and substance use. But we're also working on another one called Liberation, which is about tobacco cessation among older women, funded by Health Canada. And that, too, is an intervention that is just beginning to be developed. Again, no surprise that these titles we've chosen are as they are. As Nancy's just finished with, that notion at the base of both of these programs is that freedom, not just from that substance or from that positionality around being a survivor, but also that ability to actually make positive social change. And to get back to our roots in terms of having a critical feminist analysis about the world, the way it's organized, and how we can all play a part in changing it, no matter who we are. And that is a key part of the recovery model that we've integrated into both of these projects that we're currently working on. So we hope that that too is a way to leave you with a little bit of inspiration, that we're not just swimming around in the muck all the time in either GBV or SU service response, struggling to meet the needs of the next woman or the next crisis, but rather we're in this to change the world as well. And it's certainly true the world needs changing. So we don't forget that in the work that we do. And can we open to questions? I have some final thoughts.
I think my final thought would be just inviting people to our Strong Women presentation later today, and just mentioning that we have some materials here in case you cannot join us later.
Great, thank you.
So questions, yeah.
Thank you so much. I'm really, really glad that we are talking about how interconnected gender-based violence and substance use are. I work at Ernestine, so we're a gender-based violence shelter, and our outreach program was part of a pilot project to address the gap in services for women that use substances and have also experienced violence. So my role is working with women on substance use and gender-based violence at the same time. And trying to find other organizations and services that do that is impossible. So I'm really glad that we're having this conversation, and I'm in recovery myself. So I think it's, just so important. So thank you.
Thank you. So in the Strong Women Project, we worked with treatment centers, women's treatment centers, and anti-violence services across Canada. So it's not impossible to find them. They both piloted and then tested this intervention with us. And we really want every service to do it. But the challenge I see for you too is the issue of having others in your own community that are doing it together. And I think that is another challenge we have, is building a network of services that are both trauma and violence informed and whatever you want to call it, substance use informed, that are willing to walk together in a way that really helps women get what they need in the order and the, connected way that we'd like to see.
Hi. Hi. Okay. Yeah. So I guess I'll use it. So I actually, when I started out in the mental health field, I started in the addictions and as an addictions caseworker. And I remember it was for women, like it's a inpatient program. And that was also my introduction to GBV. I currently work in the GBV sector. And I remember when I was doing my interview for my current role, and I was like, oh yeah, I have lots of experience with it, but in a substance use sector, because every single individual that I saw all had experience with gender-based violence. So I had to educate myself on that. And I started learning about different models of psychotherapy that wasn't really trained. And then I got into psychotherapy. That's how I'm a psychotherapist now. But I was so excited for this because I was like, I want to learn more about it, how much I can do for the intersectionality. And the thing is, I see it with not just women, but also males. I have the private practice. I have a male client that I had seen for over a year before they finally let me know that they had experienced sexual assault at a young age. And at the moment, I was like trying to explore that a lot more. They cut contact, and funny enough, they got back to me today after like over a year of not reaching out. They're like, "Hi, can you session with you again?" But it's just like the intersectionality is very real, and it's something that I, coming out fresh, not knowing much about this world, I saw it right from the bat. And right now, like I definitely do believe that we need a lot more resources in that. But I feel like in my current role at the Ottawa Rape Crisis Center, like when we have clients who are dealing with substance use but also have experienced sexual or gender-based violence, we don't turn them away. Most of the time they are referred to me if I have space because of my knowledge and experience with substance use. So why this is very amazing, I really appreciate it, and I was like gonna go search out your website and everything. I'm also like very interested about like something similar but for men, because I have seen it in more than just that one client, but in men or non-binary individuals who were like labeled male at birth, who have experienced gender-based violence or sexual violence, and currently I'm living with substance use substance
Yeah.
use. Yeah.
Yeah. You know, one of the things that you mentioned there, I think is really important to underline, and I alluded to it earlier, is this idea of pacing. And when are people ready to work on the other issue? That it may not be immediate that someone wants to work on the other issue when they come in your door, and really respecting that. And that's why I was saying that if you have it as something that you mention, hey, we offer this Strong Women program for those who want to explore more the intersections down the road, please, connect back with us for that, or whatever, really honoring that, there's many roads, one journey, right? That actually people, need to be ready. And the Jean Tweed Center in Toronto, which is a women's addiction treatment center, found when they first brought in trauma and violence informed approach to their service, that they were a bit precipitous, and the women weren't necessarily ready to talk about the trauma side of things or the violent side of things. And some women kind of dropped out because they thought, oh, whoa, And so then they've set it more as a paced approach that they mention it in the context of the substance use treatment, and they offer options, like you've mentioned, for doing individual or group therapy, or just a social support group. I say just because, but that's really one of the hardest things. As steps along the way that women can access when they're ready. So even though we've talked about the importance of doing both, we mean doing both by listening to women. But if you haven't planted the seed, then they won't be able to recognize that those options are there for them. And I think that's the challenge all of our services have, is to offer dual-focused interventions and for women when they're ready.
Just want to acknowledge too that you mentioned males and men in this regard. Males and going back to the sex-related issues, have a way more capacity for substance and substance use than women, and often show up in treatment more often because they end up with more disorders, diagnosed disorders. So they're kind of out there as a problem. And there are lots of issues with respect to male use of alcohol or any of the drugs I've mentioned that are pretty serious health issues and social issues. Then there's the GBV impact, where men can be using substances, and that can be correlated with incidents of violence. So there's that to contend with. But to your other point, there's also the issue of adverse childhood experiences that affect both men and women and perpetuate the use of substances through generations.
So we've had chance, even though we're a women's health research center, we've published numerous papers recently on males and men and the impact of substances as well, and how it interacts with some of these issues that we're discussing right now about violence, interpersonal or otherwise, aggression, masculinities, and how masculinities are, performed, and how some of these issues all come together with respect to what we need to think about when we're dealing with women. So thanks for that opening there. It's very real.
And just on the issue of different sex differences in substance use, we recently heard a current program on the CBC, The Current, about the astonishingly high rates of alcohol poisoning in girls and young women who are being hospitalized for alcohol poisoning and for lifelong liver disease issues because of not understanding the fact that females cannot drink as much as males without more serious health issues such as liver disease, and not to mention breast cancer and many other things as well. But I think it's just really important that we recognize and talk about these issues with women so that they learn these things that otherwise they're not getting any information on. And I think it's a real challenge for us who are concerned with women's health as well as men's, obviously, but who are delivering services to women to be able to be informed on alcohol use issues. It is very destructive to women's health.
From young women, girls who are pressured by their boyfriends, for example, to keep drinking at the same rate. That is a lousy idea. It's not good. And it creates a lot of other, not just health related, body related, but social issues as well. Vulnerabilities, losing your judgment in the context you're in, et cetera, et cetera. So that's another form of coercion that can creep into this dynamic. Many and varied dynamics that I'm sure you've heard about, but maybe need a framework to put them in.
So we have time for one really quick question over here.
Okay, sorry, I will be really quick. Hi, thank you so much. My name is Micah. I'm from Luke's Place. One of the things I was wondering is if there's any resources or research that you folks are aware of looking at particularly how stigma towards mothers plays out in family court.
Yes, we have tons of articles on our website, plus that Mothering Under Duress study was specifically, we sat in court. Yes, so lots of articles if you go to that website of ours to really, I've written a lot about that particular issue, and it's like it is such a challenge for both the violence field and the substance use field to be able to collaborate with child welfare and to deal with the fact that the interests of mothers and children have been pitted against each other as if they were adversarial instead of wrapping care around the mother-child unit, and thinking about how do we help mothers, how do we help kids, and how do we help the unit and attachment and relational growth happen. Don't get me started. I can go on for hours.
This impinges on how you keep records and, disclosure issues and all kinds of things. It's a very tricky terrain.
But it is also, and we've learned this from research long ago, still true, one of the main barriers to women who are pregnant or pregnant for coming to treatment is their potential loss of
child custody or apprehension. And as much as we can say that is a rational thought, that is a real threat, and it's something we need to fight at the systemic level. The notion of a policy base of mother and child as a unit in policy has to become the norm in Canada, and it is not yet.
Back to that thing at the first, but I've lost the clicker. But when we first, 20 years ago, when we first talked about the intersections, oh, here it is. When we first talked about the intersections, we recreated what we saw as whoops, sorry, I'm going into someone else's presentation here. When we first described the determinants of health, this was 20 years ago. A bunch of us got together and recognized how trauma was at the center of mental ill health, violence against women, and substance use problems for women. And then we tried to define the determinants of health that mattered, right? And one of the things we talked about was public policy as a determinant of health for women, right? And instead of just all the usual ones like poverty and racism, etc., we really talked about how HIV, all these things determined women's health because we weren't making those connections, and I think they still hold true today.
And we still see instances where, you know, women get to court on other matters even and are told by judges that once they've completed successful treatment, they might get to see their children again. And then they turn around and there's no actual appropriate treatment. So, you know, that's another area that Nancy in particular has worked across the country.
Thanks for coming.